formulas comparing infants at high risk, so with family history of allergy, and they show after 1 year a decreased cumulative incidence of allergy if you use extensive hydrolyzed formula based on casein, and similarly if you use a partial hydrolyzed formula whey-based. But you don't have any results if you consider respiratory problems, not at 1 year, not at 3 years, and the measured results is based on atopic dermatitis. Why I put these slides? Because it was recently published a 10 years follow-up of these studies. And again, it's the biggest one, so it's some data that we have to rely on. And again, sorry, they showed similar results lasting up to 10 years, showing a reduced risk of cumulative incidence using partial hydrolyzed formula and extensive hydrolyzed formula based on casein, and atopic dermatitis, reduced risk of 20% more or less in high-risk infants if they cannot be breastfed. If you extrapolate the data, excluding the breastfed infants, the ones who had breastfeeding plus formula, you have more or less the same results. Again, after 10 years, you cannot show any advantage of using this formula if you look at asthma and respiratory problems. So it's just for atopic dermatitis that can be considered in high-risk infants when you cannot use breastfeeding. But why it's a hot topic again? Because another study showed different results. So they could not reach significant effect of using partial hydrolyzed formula even in high-risk infants. Just before going to that, I just know that Vandenplas published a Middle East consensus on this topic and showing exactly the same. When you have a high-risk infant with a strong history of severe atopic dermatitis, you can consider this formula. But if you look at another point of view, from a dermatological point of view, it could be more important the filagreen expression and alteration, so it's still conflicting and controversial. You have to make your choice. How is important atopic dermatitis and severity of atopic dermatitis for this family? Another new issue is that if you go to extensive hydrolyzed formula, you can have some benefit if you add in this formula a specific strain of probiotics. For what? To increase the tolerance, to speed up the tolerance in infants affected by gastroenterology, or even, as they showed in another study 3 years before, to speed up the recovery of allergic colitis. Is 100% sure? This is a recent study, a multi-center studies created by Barney Kanani and his group, and showing that if you use an extensive casein-based formula, you have a significant higher oral intolerance, increased if you put in the same formula Lactobacillus GG compared with all other formulas that you can use. But they are designing a new studies blind, because the weakness of these studies is this open design. So it should be confirmed. And everybody knows that if we talk about allergy and prevention, many other factors can be considered: microbiome, environment, pollution, smoking, antibiotics, cesarean section, and many others. So it's difficult to extrapolate one single factors. probably most of you know this. I consider this a fantastic clinical practical paper because it was published 1 year ago, and it gives you some practical algorithms extending from cow's milk allergy and the symptoms of allergy, whatever symptoms you consider from a gastrointestinal point of view, IgE based or non-IgE based. And you can switch to some special formula, extensive, less extensive, but just for prevention, or amino acid formula just for severe case like anaphylactic cases. Moving to functional gastrointestinal disorders, according to Rome 3 criteria, you have many different functional gastrointestinal disorders, starting from the early life. And it's really clinically important because everybody has experience on traveling with parents of infants with functional gastrointestinal disorders. It's very common, regurgitation, colic, constipation. And it's not just a mild condition. It sometimes has long-term effect. I will not go through details of that because our next speakers will cover this topic. But one point again is that if you consider regurgitation and not reflux disease, you can move through, reassure the parents, educate the parents. It's probably 90% of the time a self-limiting condition, but in some infants you have a high parental concern and then switch many formulas without any reason, or they go through investigation, or they want to have drug treatment, and it's not really correct. So we have some dietetic advice, new formulas. It's not just vintage formulas, but they consider new data and research results. Like these studies, it was a double-blind prospective study using 2 different formulas. Both formulas were thickened with locust bean gum, and one was partial hydrolyzed with added starch, and both formula had reduced regurgitation, but the ones with added starch and way partial hydrolysis got better. And sometimes you're concerned about constipation if you use a thickened formula, but with the new formula you don't have any negative effect on it. And then, going to extensive hydrolysis, you can have nice results both in infants with cow's milk allergy proven by challenge and with infants without cow's milk allergies. If you thicken the formula, you can get better results in the ones who have negative challenge. Why is that? It's because so many kids have allergy? No, it's because of gastric emptying effect. You speed up your gastric emptying if you use a partial hydrolyzed formula, and even more if you use an extensive hydrolyzed formula. So, if you have a good results with infants who speed up regurgitating and vomiting, you still have to decide if it's really allergic one, or if it's an immunological effect, or if it's based on gastric emptying effect. So you have to challenge after a while to prove if it's allergy or not. And going back to the guidelines, dietary changes can be considered for both happy spitters and for the ones who is not thriving well. Happy spitters do not need investigation. You have to reassure the parents, just decrease the volume they drink and the feeding, because most of them are overfeeding. So they regurgitate because they are overfeeding. But in the ones they keep on having problems, you can consider dietary changes with new formulas. And with this kind of approach, you can reduce parental concern, regurgitation, additional symptoms like crying, sleeping, feeding problems, and in some cases you have weight gain. But not all the formulas are the same, because they have used different thickeners like carob, bean gum, or rice, or corn, and they have different effect. And they can use casein-based that slow your gastric emptying but increase your satiety, using weight-based formula. And then osmolarity, viscosity can be completely different. Some of them are partial hydrolysis, some others are extensive hydrolysis. Not the same. Moving to another topic about constipation. It was recently published, these guidelines, very nice. They consider both infant and older children. What do they say? Just look for warning signs. And first of all, define what is constipation in infants, because it's really difficult for the parents. They misunderstand. Sometimes it's infantile dyschezia. You don't want to treat them. You just want to reassure them. Some others are real constipated. It means rare, painful defecation. So you want to treat them. How can you treat an infant? Well, if it's breastfed, probably you can go through, if it's really severe, you can go through lactulose in very early ones, and then you can move to polyethylene glucose solution after 6 months. And polyethylene glucose solution is a fantastic drug because it has no side effects. It's not like stimulants. It just keep on take water in your stools, and then it's softer your stool, and you can use when they are 6 months or older, but you have to use high dose, and you keep on using that for months, because otherwise they will come again, constipated, with painful, crying, and it's a vicious cycle, and the stools will get hard, and they will keep on having problems, and even the worse regurgitation and vomiting. But first of all, you have to exclude red flags, so you can treat how long as you want, but exclude red flags, neurological abnormalities, spinal abnormalities, developmental delay, signs of allergy, celiac disease, and that's it. And then again, you can use some algorithms, practical ones. I will not cover colic, it's a real nightmare, so I will leave the other to do it. I'm very happy not to cover colic. And just to emphasize one point, so it's incredible, there is an incredible humor about this. 5 drops a day keeps the colic away. It's a fantastic title from Newsweek and New England as well. Is it really true? I will leave there to give a special answer. There are some new data coming on. It's a complex network involving microbiome, behavior, neurotransmitters, immunomodulatory effect, and still going on. Why I put in my topic? First of all, because you have a meta-analysis now. Cochrane review will come in the next month, showing some results. I really do not understand why they work on breastfed babies with this kind of strain. Go through formula-fed babies that have no probiotic inside, and then they can get better results. But anyway, is so sure? No. Because just a few months ago I prepared this study. A lot of criticism, a lot of rumors. Maybe we will leave for discussion and come back again, proving not so much better results. But a multi-center studies say that the same Reuteri strain can be given as a prevention effect to reduce regurgitation and colic starting from birth, and you can get an effect at 1 month, but even more at 3 months. I don't know, that you can have some economical effect saving per patient for family and for the community, and economical problems worldwide or in Italy. So moving to eosinophilic esophagitis, very complex scenario. I don't know exactly the prevalence. It's increasingly high in the States, in Europe, I don't know, in the Middle East. It's very complex because they have some clinical features of reflux and allergy, especially in infants, maybe vomiting, feeding problems, failure to thrive. But on the other hand, if you look at older children, they have some epigastric pain or pyrosis, but they have specific features. So try about eosinophilic esophagitis if you have a child who has food impaction and severe dysphagia. Then you are not sure that you have eosinophilic esophagitis. Still have neurological problems, still have motility problems, still have allergic problems, or just severe reflux. But if you took a biopsy and you get more than 15 eosinophils per high power field, you get a diagnosis of this kind of disorder. Then, why is hot topic and complex? Because in these patients you have 50% positive allergy test, but sometimes, and peripheral eosinophilia. But sometimes just an association is not causal relationship. So it's still hot topic because you don't know exactly if they're going to respond to diet, and depends on the country, they go for empiric elimination diet or targeted elimination diet based on the most allergenic foods, 6 most common allergenic foods. On a severe case of amino acid formula, it's not really practical in older children. Or you can discuss with the parents and use fluticasone, as you use in asthma, but swallowed, so it can reach the esophagus. How can you decide? Because sometimes you have positive allergic tests, but they will not respond to diet. And how long you keep on the diet? When you reintroduce the food, and if they relapse, how can you keep on having such an elimination diet in big children? Don't get lost. I'm not a basic scientist, but it's a color pictures, okay, and showing some different colors with microRNA. Epigenetics is on fashion, epigenetics everywhere, okay. But why I put it, why for me is important, from my point of view, because they can distinguish, and in the future, in the next coming years, distinguishing this kind of colors, macroRNA, will tell exactly that which ones will respond to diet and which one will respond to fluticasone. So it's practical. Okay, so it's a clinical application that we can get in the future. Just test and you will say to your parents, you will respond to fluticasone and you will respond to the diet. Acute diarrhea. Another guideline published, updated, but not surprising. Oral radiation solution is the first and the unique treatment that you need. It should start as soon as possible. Enteral rehydration is better than intravenous, and oral rehydration covered 96% of these kids. Breastfeeding should never be interrupted, of course. And then you restart early refeeding with normal diet. Don't wait. Just rehydrate and eat. Again, they put probiotics, some specific strains. The osmic diet depends on the country where you live, you use or not. Racecadotril, especially for secretory diarrhea, it works very well, inhibiting antiphylinases in the intestine. Anti-infectious drugs, very selective cases. And about motility and vomiting. Don't use any more domperidone during acute gastroenteritis because it's not very effective. And you have some warning cardiac effects that are unpredictable, like elongation of QT C time. If you really want to use an antiemetic drug, probably ondansetron is much, much better with less side effects. Why they put a caution? Because a new study was just published a couple of weeks ago saying that If you use ondansetron in a very severe case of vomiting during acute gastroenteritis, just use one single oral dose, and you don't get any warning side effects, cardiac side effects, but it wasn't published before, so we just did some more studies. About probiotic, any new data? Really not. I mean, the strongest evidence belongs to these two strains, Lactobacillus GG and Saccharomyces boulardii. But you have to use high doses and start it soon, more than 10 doses, and it's billions, so you cannot use just a low dose because it does not affect your diarrhea. And if you use these kind of strains, you reduce 20 to 24 hours the duration of diarrhea. Some other probiotics are coming, but up to now they have lower evidence of efficacy. If you live in a country with zinc deficiency, not eating meat and fish, you have to think about supplement with zinc. No efficacy if you give them prebiotic or symbiotics. Moving to the last, celiac disease. Everybody in Italy likes celiac disease. And we are quite happy that a couple of years ago was published these new guidelines. I don't know how it's spread in the Middle East, but for us it's very, very nice guidelines. Because if you have clinical symptoms, these wide, broad clinical symptoms of celiac disease, and keep on gluten diet, and then test for transglutaminase, fantastic antibodies. Just be sure that you have your normal IgA, in your total normal IgA, because it's based on IgA class. But if you have transglutaminase more 8 times normal values, positive HA or DQ8, specific for celiac disease, you have the 4 pieces of the puzzles and you can skip esophageal biopsies. In all other cases, you keep on doing endoscopy and biopsies. But it's hot topic now in Italy because they say, if you are not symptomatic, but you have 10 times transglutaminase, is it really necessary? But it will be for next talk in 2-3 years time. And if you are just at risk group, like first-degree relatives or other autoimmune conditions, how is the algorithm? You start from HLA. You test HLA. If it's DQ2 or DQ8 positive, you have to test for transglutaminase. If you are DQ2, DQ8 negative,